Hello again, and hope everyone had a few minutes for a break. We are moving on to our next panel, and I have the privilege to introduce the moderator of this panel, Dr. Ravi Prasad. He's a pain psychologist at University of California, Davis School of Medicine. He's also their Director of Behavioral Health Services and clinical professor in the Department of Anesthesiology and Pain Medicine. Dr. Prasad has a number of other important things in his background, as well as involvement with our past work with AACIPM, and as well as many others do. So just a quick reminder, in presenter bios, I encourage everyone to look and see about really the excellent backgrounds that all of our leaders bring today. I'm excited to turn this over to Dr. Prasad and continue with this panel. So to you now, thank you.
All right. Thank you very much. And I'd like to start our session by first recognizing Amy Goldstein. Amy has really been the AACIPM, and really the effort that she's put forth in converting what's been a live 2-day conference into something online in a very short period of time, and to do it with the success that she's done. I think we had over 800 people register for the conference. It's nothing short of incredible. And so she's put a lot of work in behind the scenes, and I want to thank Amy for all that hard work. So thank you, Amy. I've spent the last 16 years implementing integrated interdisciplinary treatment models for pain in clinical settings, developing training programs to educate clinicians on biopsychosocial pain etiology and treatment, and most importantly, also being engaged in active care. When I first started in the field, just like many of you, my intentions were very pure and simple. I wanted to do whatever I could to help alleviate the suffering associated with pain. Over the years, though, my clinical experience has helped me appreciate that providing great care is necessary, but it's not sufficient to help alleviate suffering on a larger scale that's necessary. There are a number of overarching contextual factors that directly influence the care that we provide that we need to be aware of, 3 of which we're going to talk about today. The first is the evidence base. We need to make services that we're providing to our patients are evidence-based, that there's a robust scientific literature to support what it is that we're doing. Now, this has positive implications for the safety of our patients because when studies are done to look at the effectiveness of a treatment pathway, not only are they looking at that efficacy, but they also look at potential harms. And so patients can be rest assured that when they're participating in a particular form of treatment, this cost-benefit analysis has already been undertaken. Also for clinicians, this can actually allow for some standardization of our treatment and improve the efficiency of our practices. If I know that somebody is coming in with non-radicular low back pain, I have an armamentarium of treatments that I can use to help move them along in their treatment. If somebody comes in with cervical radiculopathy, I've got my armamentarium of treatments that I use for that. And there's a decision tree that I use to determine what the most appropriate treatment pathway is that's all guided by the evidence that's out there. And then finally, it's important for payers as well. It can be beneficial for payers in that it helps them determine what are the different treatments that we support and the ones that we don't. It makes sense for payers to support those things that do have robust literature backing versus I think that there's any agreement among any of our panelists or any of the people that are on the line right now that it's important to have scientific evidence to back what we're doing. The challenge is what evidence do we follow? Sometimes there are conflicts between the different clinical guidelines that are out there. More importantly, there can sometimes be discrepancies between the guidelines that are used. So the guidelines that clinicians use to guide their clinical care versus the guidelines that are used by payers to determine what to reimburse. Sometimes these things aren't parallel with each other. Another one of the overarching dynamics or domains that we need to be aware of are treatment outcomes. Beyond providing care, we need to demonstrate that interventions that we're implementing are resulting in some benefit to the patient. Now, this is an excellent progress toward patient goals, and this helps facilitate person-centered care. This also helps implicitly support a dynamic treatment pathway that flexes as responses to treatments vary. And this provides assurance to the payer that the treatments that they're providing coverage for are resulting in some sort of change, or that that change that it's coming out of their treatment is being monitored. But again, just like with the evidence base, what outcomes should we use? How do we chances where there may be different standards used to assess treatment efficacy by researchers, by clinicians, by payers, or by patients? And then lastly, it's our ethical and moral responsibility to ensure that we have the appropriate training to provide the services that are being rendered. Moreover, we should never go beyond the scope of our providing care. Now, the presence of core competencies within disciplines can help create such standards. But who determines what these standards are? And how is competency addressed, or assessed rather? Is this something that's based on licensure? Is it based on the degree that somebody has? Or is it based on certification, based on education or CEs? So for example, just because I'm a licensed psychologist, does that mean that I possess the competency to be a learning disability specialist? I think all of us would agree that learning disability certainly falls within the wheelhouse of psychologists, but just because I'm a licensed psychologist, does that mean that I'm competent to do that kind of practice? So it's clear that understanding or issues related to evidence-based outcomes and is really necessary to advance value-based pain care. But this reconciliation has to occur with all relevant parties at the table. The researchers who conduct studies that guide clinical practice, patient care, persons who are living with pain, who are the recipients of treatment, and the payers who provide coverage. So AACIPM has drafted a paper and an evidence grid to help some of these discussions. And we'll get this, or you actually have a sneak peek of the evidence grid in the materials that you have online. But today we have a highly influential panel to stimulate some of our thinking in this area. And so I'm pleased to have with us Dr. Sherry Ling, the Deputy Chief Medical Officer for CMS, Dr. Christine Gertz, Professor of Musculoskeletal Research at Duke and Chair of PCORI Board of Governors, Dr. Adam Steiner, Chief Medical Officer of the Hartford Insurance, and Dr. Bo Anderson, Director of the Institute for Health and Wellness at Monmouth University. So each of our panelists will share some of their perspectives, and then we'll have some discussion. And we'll go ahead and start with Dr. Ling.
Hello, good afternoon. Are you able to hear me all right? Someone give me a thumbs up or a excellent. Thank you very much. It's indeed an honor to be with you. And again, Amy, echo thanks for your organization and your ingenuity getting this all together so quickly. We remain very supportive of all the work that needs to happen and is happening in order to provide care and services to our beneficiaries. So really appreciate all that you all are doing. And these are extraordinary times. And I was able to listen in a bit on the last panel and thought I would start with, so if I could have the first slide, please, or next slide, that would be great. So just go ahead, please, one more. So I need to show you my disclaimer to say, suffice it to say, I have no financial conflicts to disclose, but the information I will be sharing with you is really as current as we can make it. There are no obligations incurred by presenting this information to you, as this is really by way of a public service, but I am really interested to know, particularly in reflecting upon some of the comments that were made in the last panel about, what is happening out there in care and service delivery, and what options are there to provide such services in light of a public health emergency like the one that we are currently in. So really, thank you very much. And next slide, please. So just a reminder, so CMS is part of it. We are serving in an agency that's part of the Health and Human Services department, and we have a overarching strategy that CMS's work actually fits into, which is about improving the healthcare delivery system and really thinking about ways that we can improve health outcomes for the people who we serve by reducing administrative burden and improving and encouraging the improvement in the quality of care that's delivered. And of course, you know, as we think about value, that value conversation is both informed by quality as well as cost. And so we are mindful that our major role, CMS's major role in this conversation and evolution towards value-focused care is that one of a payer. So I'm going to provide comments that really, you know, mostly from the Medicare perspective, because I think that is where we have finalized a policy that directly addresses pain and the ability to cover services for pain management in a very specific way that I think you all have expressed interest in, and Amy had requested that we provide some information of how things are going since our finalization of the acupuncture coverage determination. So next slide, please. So just as a reminder, CMS remains the largest payer for healthcare services, and we touch upon approximately 1 in 3 Americans. And Dr. Ostrovsky provided some perspective from the Medicaid side, and I'm going to try to focus my remarks on Medicare. But next slide, please. The clinical context, or the context of who we serve in Medicare, is really critically important. It's an important context for purposes of not only clinical practice, but also research that comprises the evidence upon which we build healthcare policy. The authority CMS has is complementary and distinct from the evidentiary requirements that FDA has for safe and effective. In Medicare and Medicare policy, it goes beyond that. The requirements really speak to, and Ravi mentioned this, the importance of that a treatment and service would be reasonable and necessary, and that there's evidence to suggest that a treatment or service is not only reasonable and necessary, but also then results in improved health outcomes or outcomes. And I think one of the challenges that we have is that scientific studies are really driven by the research question, which is wonderful, but the outcomes that are selected often are quite diverse across studies. So one challenge to us as a community is how can are there some core outcomes that would be, could be agreed upon in future studies as we go forward. I show this slide because this actually just demonstrates in one glance why outcomes and the question of outcomes in the Medicare population is so critical. And on the left of the slide is this is a fee-for-service population glance, cross-sectional. What is in blue is the population that really has just one health condition. So if we pick, let's say, arthritis or osteoporosis that could result in fractures and painful symptoms, you can see that what is in blue is a really tiny sliver of the total Medicare beneficiary population. What is in purple on the right is that percentage of the population that has 5 or more other health conditions. And I am a practicing geriatrician and also rheumatologist by training. I will say that the context for who the people are who we are serving and how one would manage symptoms in an individual has to take into account the complexity and the other comorbidities that beneficiary, that patient has to, we have to be able to manage towards. So outcomes may be determined not only by painful symptoms, but the other comorbidities that challenge the clinician, as well as the medications and treatments and services that then it becomes really a complicated picture and necessitating the question, answering the question, what is the clinical utility of any treatment and services? Next slide, please. So specific to acupuncture, so back in, as of January of this year, the policy is that CMS will cover acupuncture for low back pain under this specific section of the Social Security Act. This is specific to chronic low back pain. We have an operational definition of chronic, 12 weeks or longer, and the other characteristics that are required for this coverage are specified in the national coverage decision, and that document is findable, searchable, and understandable in full detail on the web. We did set a limit as far as how many treatments, and also the provision that if the patient is not improving, then it would be the expectation to discontinue this treatment. Next slide, please. So this is, and with Medicare, remember that Medicare is, and what is coverable is written in statute. There are specific Medicare providers that are identified in statute. And so we have the final policy is that physicians may furnish acupuncture in accordance with the applicable state requirements. And I know there's interest in, so what would count as requirements to fit into this category? And so we've kind of laid it out in the final policy, but this also was addressed in the proposed policy where public had the opportunity to provide comment. We do actually say that, you know, the additional personnel and professionals can furnish the service, but because of the statutory requirements, the service has to be delivered what we would call incident to. So I think that's an important point to remember as far as who is payable directly by Medicare. Now, keep in mind that Medicare Advantage and states through Medicaid have more flexibility in the interpretation and implementation of these services, but for Medicare fee-for-service, these are the requirements. Next page, please. Next slide. So as I mentioned earlier, the way that coverage happens is really determined in statute, and the language is as it appears here. No payment may be made under Part A or B for any expenses incurred for items or services that are not reasonable and necessary for the diagnosis or treatment of illness, injury, or to improve the functioning of a malformed body part. So we interpret this as improving outcomes. And the defined benefit programs are as described. We have beneficiaries who are beneficiaries by way of an age threshold, but also people with disability and end-stage renal disease. And then the benefits actually have to fit into a category that is healthcare providers, healthcare settings, and so on and so forth. Next slide, please. So we have the ability, so Medicare's ability to cover on a national basis, as well as under, go back one, please, under the discretion of local contractors, and where there is a national policy, then that supersedes the local contractor discretion. Now, why the acupuncture national determination was so important was because there was a national non-coverage for acupuncture previously, and we were able to finalize the national coverage of acupuncture for this specific indication with the restrictions that have been mentioned, but in doing so, then permitted access to this this helpful service. Now, one of the disadvantages or major gaps that when we looked at the evidence, as you recall, the initial proposal was coverage with evidence development, and with public comment and the provision of additional information, including data, we were able to really fill in some of the gaps in evidence. But by and large, I will say most coverage requests, when we look at the evidence, the reason that they are declined or turned down or not finalized is because there's not sufficient evidence in older adult populations. So we were able to amass the evidence that were, and public comments that were supportive enough for that so that we could finalize as a national coverage determination with the limitations and constraints, but so that we did not finalize under coverage with evidence development, which is an interesting construct where a treatment or service can be covered as the evidence accrues. So next slide, please. So just to give you an idea of, this is just a process depiction of both the timeline as well as, you know, how we look at the evidence, where we look at the evidence. We occasionally will convene Medicare Evidence, a committee to advise CMS on and opine on the sufficiency of evidence if that is necessary. And public comment is always part of this. What is important about this slide is that not only do we have specific requirements that CMS has to meet for statutory reasons, but we also have a timeline that is laid out in statute. So it just needed to let you know that, you know, when we open a coverage determination, the clock has started, and we want to do our best to be able to stick with those timelines because it is laid out in statute. Next slide, please. So the question was asked in our prep, so what about other treatments and services? There are many available. What we chose to do as part of our approach to improving access to pain management services was to actually publish a Medicare Learning Network document that summarized those non-opioid treatments and services that are covered by Medicare. And this is one you can actually just Google search CMS, MLN, pain management. Next slide, please. There are additional treatments and services that are covered by way of local contractor discretion that it was just too much information to provide, but we do have a Medicare Coverage website with a searchable window that will allow you to pull up, if you wanted to put in a keyword, acupuncture, for example, it will generate a list of all the national coverage determinations, national and local, and where they are covered locally, if there's not a national policy. So we chose not to include that whole list rather than point to where you could find it in the MLN article. I will say that, you know, effective pain management is also opioid overuse prevention. And that has been included in one of our pillars in the opioid roadmap for 2019 and also 2020. I will flag for you that the Support Act is a law that CMS is implementing two provisions of note for your for completeness and for your information. One is section 6032, where CMS is responsible for reviewing various payment and coverage policies for treatments and services to manage both acute and chronic pain. CMS was required to consult with the Pain Management Best Practices Task Force that my colleague and dear friend Vanilla Singh was leading while she was at HHS, and a report to Congress, a report of the plan and the report to Congress is forthcoming and will be posted publicly as soon as it is cleared. I will also mention there's a separate provision, section 6086 of the Act, which is also referred to as the Todd Graham provision. This provision requires really us to look at and consider and evaluate treatments and services specifically for pain management. And we are doing this in collaboration with our colleagues in across HHS. So that information also will be forthcoming shortly. But this is also findable on the web. So appreciate your attention and thank you.
Well, thank you very much, Dr. Ling, for sharing all that information. You know, CMS paves a way that a lot of different payers follow in terms of coverage and reimbursement. Helpful to get a glimpse of the complexities involved with determining how coverage gets addressed, what things get covered, and how that applied to acupuncture. So thank you for sharing that. I know that we had a question from members of our audience. We will address all the questions, or as many of the questions we're able to, after all the panelists have had a chance to share some of their thoughts. So feel free to type them in and we'll address as many of those as we're able to after all the panelists speak. But with that, we'll go ahead and pass it on to Dr. Christine Gertz, who will share some information now from her perspectives. Dr. Gertz?
Great, thank you. Thank you so much, Ravi. And I just want to thank AACIPM for providing the opportunity for all of us to come together during this difficult time. It's just, this is a great forum, and as others have said before me, special thanks to Amy Goldstein for just doing a terrific job of not only coordinating all of this, but also coordinating us, you know, all of these speakers, you know, including myself. I'm very grateful. This slide includes a list of my affiliations, and I want to let you know that I have no conflicts to disclose. Can I have the next slide, please? Today I'm going to be talking about outcomes in integrated pain management related to three different questions. The first is, you know, what outcomes are currently in common use? The second is, you know, who decides what outcomes matter? And then finally, you know, why is outcome measurement so important? Could I have the next slide? So there are literally thousands of you know, probably 1 million different outcome measures available, but they tend to fall into some pretty basic categories. So the first is patient-reported outcomes, and more focus on things like pain intensity, pain interference, and physical function. And several years ago, I think we focused a lot more, at least from a research perspective, on pain intensity. But as we've conducted more studies on pain management, there seems to be more acknowledgement that things like pain interference and physical function may be even more important to patients' daily lives than pain intensity at any particular point in time. And also things like patient satisfaction, adverse events, costs, healthcare utilization, and then medication usage, which as we begin to focus more and more on the opioid crisis, we've started to pay attention not only to opioids, but what are other medications that are currently being used for pain that might be important to measure. Next slide, please. So the first thing that I want to focus on are who decides what outcomes matter when we're trying to figure out what to concentrate on. Sherry mentioned earlier that the need to harmonize or to come to some agreement about the types of outcomes that we use in research studies. And I think that is really important, but not only for in research, but also what outcomes matter to patients, to clinicians, to payers, purchasers, healthcare systems. Next slide, please. So in many ways, the people that, who gets to decide what outcomes matter, I think is a really important question. And in just the simplest sense, you have to look at, what are some of the sources that we use in order to collect outcomes data? And that ranges from electronic health records to clinical data registries, to the research that I mentioned previously, to insurers and claims data, public records. All of the data we're now able to collect with wearables or smartphones. So these are how, in order for outcomes to matter, they have to be gathered in a manner so that they can be used to try to figure out, are patients improving, what is the cost of the care, what types of services are they utilizing, et cetera. And these are the mechanisms that we currently are using in order to gather that data so we can use it for all of those purposes. What I want to do is I want to focus really on three different sources of data. First, the research studies, next, clinical data registries, and then CMS, for many of the reasons that Sherry talked about and Ravi mentioned. CMS is our largest payer in the United States, and many other payers and others look to CMS for direction when it comes to various payment policies, but definitely outcomes as well. Could I have the next slide? So the first thing I want to talk about a little bit is research studies and how is the decision made for regarding what information we want to include in research studies. And I'm going to be talking about more specifically in clinical trials. And I can tell you that in my 20 years as a PI of probably about 20 randomized clinical trials now, and looking primarily at pain in one way or another. Early on in my career, there was really a push, and I was studying primarily manual therapies, and there was a real push to try to focus on outcomes that were seen as hard outcomes that were that wouldn't perhaps have the bias that used to be more associated than it is now with patient-reported outcomes. So with looking at spinal manipulation, looking at things like postural sway and sudden load, and how were those things impacted by spinal manipulation. And what we found is that that was pretty unclear in a number of the studies, but then it also begged the question of, why does it matter? Do we really know how these outcomes contribute to patient care, and really started to switch more towards patient-reported outcomes. And part of that effort then is, if we're trying to study similar aspects of pain management, can we come together, as Sherry mentioned earlier, on what outcomes really matter? Could I have the next slide, please? So NIH attempted to do that for chronic low back pain several years ago. They brought together a task force to develop basically a minimum data set for studying chronic low back pain in clinical trials. Can I have the next slide? So what this report really included recommendations for a definition of chronic low back pain, which I will tell you that after spending about a year on it, our definition of chronic low back pain was chronic low back pain. So we did put some parameters around how long you had to have pain, but that ended up being something that sounded very simple and was a lot more complicated than you might think when you really start delving into how complex the condition chronic low back pain really is, and all the things that need to be considered when you're thinking about a minimum data set. And this task force really called for greater consistency in reporting to facilitate comparisons among studies, as well as the development of phenotypes for back pain. Could I have the next slide, please? So here, we basically came up with a minimal data set, and this just gives you the first page of that data set. But the thing that you might want to focus on is really the hyperlink at the bottom, which is where you can get the entire form for this. And I'd be happy to send this information to anyone also if you're afterwards, if you're interested. Could I have the next slide, please? So the next group of folks who really have a lot to say about what outcome measures matter for pain management are those who are in charge of developing and choosing performance measures for clinical data registries. Next slide. So we all know that clinical data registries, there's been a big push. I think I'm crediting CMS for really helping the country move in this direction, but a big push towards clinical data registries in order to identify best practices, enhance healthcare quality through feedback and benchmarking mechanisms, to open up a dialogue between clinicians and payers, purchasers, policymakers, and other stakeholders. And then last but certainly not least, to build a community of clinicians who are committed to data-driven healthcare delivery. Can I have the next slide, please? So as we've there are, I think CMS, Sherry, you can correct me during the Q&A if I'm wrong, but I think we have coming up on about 300 performance measures now in the Medicare Quality Payment Program. And so it can be really daunting to try to figure out what should a minimum data set look like especially for pain conditions. But I think there's more and more of consensus about what those performance measurements should look like, and really looking at making sure we include information about patient characteristics. Diagnosis and comorbidities is really important to include, given, again, the slide that Sherry showed about our Medicare population and the large number of people who have more than one comorbidity. That's certainly very true for people suffering from pain. Clinical response, including patient-reported outcomes, medication usage, adverse events, utilization data, cost, and then patient satisfaction. Could I have the next slide, please? Okay, and then just related more specifically to CMS, next slide. So I haven't been able to listen to the entire conference. I'm not sure to what extent we've talked about the CMS Quality Payment Program. I think that this is, in many ways, the QPP, which started both a merit-based incentive payment system and advanced alternative payment models, has really taken a lead role in helping to advance us towards the goal of performance measurement, and also helping to set standards about what outcomes matter. And I just want to show the next slide, which shows several performance measures that were included in 2020 by the CMS Quality Payment Program that are directly relevant to pain management. And then there are literally dozens of other measures that are related, in other ways in regards to depression, measurement for depression and anxiety, and other aspects such as obesity that may be directly relevant to pain management as well. Next slide. So we talked a little bit about what outcomes people are starting to focus on more, but the thing that I'd like to finish with is, why are outcomes important? Next slide, please. Well, one reason is because, you know, and thank goodness our payment system is moving, you know, from volume to value, and trying to figure out, you know, how can, when we're looking at value, it's not only a cost equation anymore, but outcomes need to be an important part of that equation. And in order to move towards more value-based payment systems, we have to focus a lot more on outcomes than we have in the past. So second, outcomes, next slide. Second, outcomes really have the ability to influence patient care. So if we're looking at not only moving away from just looking at the cost of services, but the risk of various services. So the reason why we're hearing so much about opioids and the opioid crisis is because over time, outcomes are showing us that that the risk associated with opioids may in many, probably most cases, outweigh the benefits that are available to patients, except in specific circumstances. But it also provides us an opportunity to identify best practices in terms of both diagnosis and treatment. Next slide. The third is that this is sort of what it looks like now when a person with back pain is looking for care, and we're starting to learn that the patient care that a patient outcomes in the long run probably is more dependent on whose office they happen to stumble in first and what care they happen to get initially than their actual underlying condition. And so outcomes, as we find out what works, and specifically for what pain conditions and what populations, it gives us an opportunity to move from this, you know, sort of very messy patient healthcare trajectory to, next slide, to something that's a little bit more streamlined and focused on making sure that patients are getting the right care at the right time, you know, starting with the most conservative care possible and moving from there to more more intensive care as their condition warrants, after they've tried things that are are more conservative. So really starting with looking at things like nutrition and physical activity and mindfulness and patient education, you know, before a patient even enters the healthcare system, and then looking at what we do call facilitated self-care, which are things like yoga, tai chi, exercise, cognitive behavioral therapy, and then looking at really a focus on clinician-driven care at the primary care level, either primary care physicians or primary spine practitioners for that next phase of care, and then moving from there to PM&R, anesthesia, radiology, and spine surgery when it's necessary, and obviously making sure that that people have access to appropriate care at any point in the trajectory as it's warranted. Next slide, please. So many of the treatments that you saw up on the top of the funnel are actually treatments that are currently recommended by any number of guidelines, and AACIPM has done an excellent job of pulling together information on what the current guidelines show are recommended by any number of both public and private entities that have put those guidelines together. But just to give you an example of one of those is the American College of Physicians, who published a guideline for treating low back pain a couple of years ago. And can I have the next slide? And what their recommendations actually are that patients and clinicians consider treatment for acute, subacute, and chronic low back pain with a number of the non-drug therapies that you saw at the very top of the funnel that I just showed a couple of slides ago, including massage, yoga, tai chi, and spinal manipulation before any prescription medications. So it's really a movement towards, there's definitely a movement in that direction, but I would say that there's more talk than action so far as we move in that direction, and that would be the final reason that I'm going to talk about today about why I consider it to be so important to focus on outcomes. Could I have the next slide, please? So when I'm talking to payers and purchasers and healthcare systems about why there hasn't been more uptake of some of these integrative practices within integrated pain management, I hear concerns about quality, about consistency, and about transparency in terms of the services that are delivered, the ability of clinicians to be able to deliver those services. And I would argue an example of this that CMS has had to deal with recently is in making coverage decisions about acupuncture. So what do we know about the quality, consistency of the care, and who is best positioned to deliver that care? So outcomes actually provide us with an opportunity to move from these issues as question marks to, could I have the next slide, please? To more definitive information about them, so that we have actual data that allows us to evaluate quality, allows us to evaluate consistency, and to be more transparent about what practices work best for what patients. Next slide. So thank you very much for your time today. I really appreciate it and look forward to the question and answer session.
Thank you very much for that excellent overview of the importance of outcomes. We'll move on very quickly to Dr. Adam Steiner to share with us his thoughts. Dr. Steiner.
Thank you very much. I hope to expand on a lot of the concepts already put forward. My conflict of interest disclosure is that I'm a salaried employee of the Hartford. One of the things I do bring are multiple perspectives. So not just as a physician, principal investigator, the insurance perspective, my public health perspective, and also my anthropology perspective. I just want you, when in my job as chief medical officer, I really use all of my certifications and degrees equally. And it helps be able to get, to the right place with regard to many policies. So one of the things I just want to point out is that, conventional medicine aims to diagnose, treat, and cure or alleviate symptoms. The integrative approach really aims at relieving symptoms, yes, but restoring wellness as well as help patients in a process of self-healing. And I think we need to recognize that as we go forward and really go beyond just the traditional biopsychosocial approach to more of a health systems approach. And for those that aren't familiar with that term, Dr. Friction out of the University of Minnesota has published and put together quite a number of nice resources so you can look at the health systems approach. Next slide. So basically my outline is I'm going to talk a little bit about quality of evidence, share another payer perspective, talk about value propositions where I'll kind of end. Probably won't spend a lot of time at all about shared decision making, though I think it is a very important piece to appreciate and basically appreciate the value of an integrative approach. We have to be able to formulate a basis for program development, primarily develop strategies for an integrative approach. So all of this. So what's the medical science? There's different types of studies. There's experimental and observational. There's quality. The quality of the evidence is important. in how strong we can recommend a treatment or recommend against a treatment, or if we have not enough evidence to make any recommendations. So it's important. And I just want to talk about consensus statements for one moment here, because when we have a panel of experts on a scientific or medical issue, you know, the terms of recommendation and evidence-based or guideline really shouldn't be used. This is an opinion or suggestion, and you'll see why on the next slide, which I'm not ready for yet. So basically, we have to have really a rigorous evaluation of the integrative or any approach, and it needs to be comparable to what we use, I think, in conventional medicine. The challenge for research here is really the methodology is needed to fuse the philosophical concerns of stakeholders with the highest standards of methodologic rigor. We really need to fuse that, and we need to pay attention from the mainstream science people here to take the concerns and criticisms about trying to achieve a randomized controlled trial very seriously if we're going to be able to fuse and reconcile those issues. Next slide. So here's the standard pyramid you've probably seen many times before. Sometimes it includes some of the in vitro and animal studies as well. But the reason why I wanted to just address the consensus statements is, you know, it falls really to the bottom of this pyramid, and the quality of the information improves as we go through. The problem that I've had over the years is I think many payers use this inappropriately as a filter to get to a point of non-coverage, because they're always looking for that randomized controlled trial. But there's plenty of other good research out there in cohorts or case control studies that are very helpful in determining what is beneficial. And so we need to really pay attention to those studies as well. The main things I want to focus the group here today on is a few areas. Generalizability. So we really need to have the understanding of what's generalizable, because especially with an integrative approach and some of the treatments that go into that, the outcomes are going to be affected by the individual's belief system or their perception of the sick role, which can be cultural, as well as what coping mechanisms they have or don't have. So this generalizability is important, and the broad and appropriate outcome measures need to be captured. And today, I don't know if we're really there yet. The second point I want to make about the quality of information is that the standardization. There really is a challenge because, again, for the integrative practices, a lot of it treatment is individualized. And we have to also recognize the practitioner is explicitly recognized as a component or contributor to that treatment. And we don't address that all the time in the research as we're going through it. So standardization of how we understand the individualization and the role of the practitioner is important as we get to the third area, which are outcome measures. Again, we have quantitative and qualitative, but how do we capture some of the experiential outcomes for those individuals? How do we develop experiential criteria, which can lead to other things like not just the qualitative aspects, but the quality of life for that injured person as they improve their health. So important to know, it's talked about, there are validated instruments out there, you know, some of them for the musculoskeletal aspects like the ODI, which is the Oswestry Disability Index. There's also sections for low back pain. The Rebro is very good for musculoskeletal pain as a questionnaire, and it has yellow flags, which can identify those that may have some delay in recovery. So all important concepts around all of the evidence. Next slide, please. So what am I looking at, you know, from a payer perspective? And, you know, I get this a lot of times from doctors is, well, what are you measuring me on? You know, is it just cost? And I said, no. And others will say, well, is it just process? No. Is it just outcome? The answer is yes, all of those. We're measuring cost, process, and outcome. And so what we want to do is make sure that we get to an outcome that really is improved functional status. How we get there, again, is part of the secret sauce, which is the recipe that we need to still, I think, figure out and still define. So what are the things I'm looking at as we go through, hospital and the specialists or primary care? It's improved prevention, improved practice efficiencies, unnecessary, reduction in unnecessary testing, referrals, unnecessary or preventable ER visits or admissions, or readmissions from the hospital. All of this comes through to a point where we've got efficiency and lower total healthcare costs. Good medical care is usually very cost effective and does cost less than inefficient. So we want to have avoided costs, I think, is number one. Number two, I think the efficiency of outcomes, the resource utilization, the outcomes achieved, and satisfaction with services. That's very important as well. So the satisfaction, not just of the patients, but even the providers in the system. And then finally, there is something to be said about adherence to clinical guidelines. There's plenty of research out there that shows adherence to clinical guidelines does result in better outcomes, no matter how you measure them. So we can look at those studies as well, which are already out there in the literature. Next slide. So here's a slide that I just want to maybe level set everybody against. So one of the things I'm looking at is over and under utilization or over and under treatment. And so that's your y-axis here. Your x-axis here is basically accountability for outcomes and costs. So, does the provider or institution, hospital have a low or high accountability for what the cost is going to be? And the problem is with some of these different systems or payment models through history, you can look through and just, level set and say, well, is this true? Is there higher underutilization if we try to use capitation or population-based payments? What does that mean? Does it fall in the spectrum of higher or lower accountability? All of this really, I want you to think about and focus on. Really, the idea is we need to get to a patient-centered payment system, a patient-centered payment system, which will be basically one of the things I do like cost utility models and aspects of that, but it also takes into consideration, which I already mentioned, is patient preferences through this whole aspect. So as we go through this, remember, the goal should be to pay for the care of each person and or condition the right way, not necessarily the same way. And so when we're done with really understanding and going through all the experiments that we're going through, like today with quality P for P or quality cost P for P, basically we're going to have a hybrid model, because the hybrid model is going to be needed depending on if you're dealing with an acute situation, an acute problem, a chronic disease problem, whether you're dealing with prevention, services, or what we're looking at in some cases is you've got some services that are underutilized, and so to get them to be more utilized, for instance, maybe there's a low vaccination percent adoption, we need to basically go back and consider maybe a fee for service is the way to go for that. So you're going to have a hybrid reimbursement system, but keep that in mind as we go into my final slide, which really is nothing more than to ask the big question is, how do we increase the value of care? So you can go to the last slide if you want. And basically point to use to one of the researchers that I enjoy reading, and that's Michael Porter from Harvard, and basically his work on the value-based system. So how do we increase the value of care? I think we have to have an integrative approach, not just to treatment, but also to practice units, how the doctors are set up, from primary care doctors to the specialists, to the facilities that are involved, the hospital systems. Payments, I think, need to be integrated. I think technology clearly needs to have an integrative approach. The platforms, the EMRs that we're all working with, the electronic medical records, all important. And then finally, the outcomes. Clearly, we have to have an integrative approach and understanding of what the outcomes are if we're going to really get to understanding the value of some of the integrative care opportunities and services that really can help our patients. And with that, thank you very much.
Thank you so much, Dr. Steiner. Exceptionally helpful to hear a little bit about how the decision-making process occurs in one of the larger insurance groups in our country. And with that, we'll go ahead and turn it to our last presenter. After that, we'll have just a couple of minutes.
Hi, good afternoon. Thanks very much for inviting me to speak at what has been so far an excellent meeting. So I'm going to tease out some of the aspects that were brought up by the previous speakers in this session. But firstly, just a little bit about myself. So I am a researcher, an educator, and a clinician. And most recently, my research has been in the area of training faculty and developing curriculum in evidence-based medicine within Chinese medicine programs, and also undertaking acupuncture clinical trials for chronic pain for the underserved in community-based and federally qualified healthcare centers. So I'm going to talk pretty much from that perspective, and also focusing on the recent decision by Medicare to cover acupuncture. So next slide, please. So I'm going to talk a little bit about the precedent issue for this recent decision, then talk about education, especially the need for developing competencies and the implications of accreditation for securing that. And then lastly, really focus on this whole dissemination and implementation issue. Next slide, please. So the Medicare decision really has set a precedent. It's legitimized the strength and quality of the research evidence that supports the efficacy and effectiveness of acupuncture. And as Sherry mentioned, this will then be a catalyst, hopefully, for other payers to cover acupuncture, and also hopefully beyond not just chronic lower back pain, but also for a range of other conditions. And going forward, as the AACIPM creates the repository, this will provide an easy, readily available information source for looking at the evidence that exists for acupuncture for a range of different conditions. So of course, this has implications for the other complementary and integrative therapies. The decision was based on evidence, and that really underscores the importance of building a solid evidence base. And of course, this relies on funding. So it needs to be on the radar of the funders that if we're going to introduce more complementary and integrative therapies into the pain care arena, then we've got to have the funding to support undertaking the research. But of course, it's not just the research, and several other speakers have pointed out the importance of building a solid education and licensing infrastructure as a quality control mechanism, and also to better understand what exactly will be delivered, which should be reflected in the accreditation standards, and also the processes that are required to actually become a licensed provider. So next slide, please. So now sort of delving a little more into the education. So back in 2013, Fishman et al. Published pain management competencies, and those are shown on the next slide. And so these will be familiar to most of you, I'm sure, focusing on these 4 core aspects or 4 core areas of competency that are required for clinicians who are treating pain patients. So of course we can utilize these in the training programs for any clinician that will be treating pain, but we also need to go beyond these. And if we go back to the previous slide, so going beyond these, especially for the complementary and integrative healthcare providers, is a very important consideration. Now, part of the reason for this is as there's more insurance coverage for these therapies, of course, that will increase the demand, because a lot of what's holding back the demand is the fact that most people have to pay out of pocket for this. So as there's more sort of subsidized payment, if you like, this will increase the demand, and this will then directly impact the professions for these providers. So principally what I'm thinking of here is that most complementary and integrative healthcare providers go into private practice after graduation. But as the demand increases and as these therapies are therefore increasingly provided in mainstream biomedical healthcare settings, these clinicians will start to become salaried employees. And that's going to require additional training. Obviously, it's going to require training in interprofessional education, but it's also going to require sort of more basic training on how do you work in a biomedical setting and integrate with other biomedical providers. So the interprofessional educational aspect is not only important for the complementary and integrative health providers, of course it's important for all providers in a comprehensive and integrative pain care setting. And that is a real weakness that needs to be addressed. And the basis of it is very simple, is there's just a lack of understanding amongst the different professions about what each other does. And if we are going to be referring patients to a different type of provider, then it's understandable that patients will start to ask questions and want to know more. And the likelihood that they will actually follow up on that referral is going to be greatly enhanced by the ability of the referring provider to provide an adequate explanation about what that therapy is and the type of experience the patient is likely to encounter, which could be anything from cost to, you know, if I go to acupuncture, are those needles going to hurt and how many treatments will I need? So interprofessional education is obviously something that there's a significant need for. Now, when we're thinking about these additional training aspects, we really need to bring the accreditors on board with the importance of this, because ultimately what ends up in these degree programs is defined by the accreditation requirements. And so if the accreditors are on board, then these educational requirements can be mandated in the programs, and the payers can be confident that the providers have the appropriate training. Now, what's interesting with respect to Chinese medicine or acupuncture training is that the entry-level degree currently is the master's degree, but it is also permissible for institutions to be offering entry-level doctoral programs. And if you look at the competencies, the accreditation competencies for those two programs, the ones that are relevant for pain management that deal with things like healthcare systems, pain management, interprofessional education, evidence-based medicine, are in the doctoral program, but not in the master's program. So as these professions evolve, the accreditation standards are going to be improved and brought, you know, up to date, basically. And that's something that all the complementary and integrative health professions really need to focus on. So next slide, please. And the next one, thank you. So now moving on to this question of implementation. So research generates the clinical practice guidelines, which Adam talked quite a lot about. And when a profession has got to the stage of having a critical mass of research, we also have a critical mass of clinical practice guidelines. So on the next slide, so what we could see and would be an important addition to this evidence pyramid that Adam talked about is the inclusion of the clinical practice guidelines right at the top, based on the outcomes of the systematic reviews and the meta-analyses. And on the next slide, you'll see how with acupuncture research, as the amount of research increased over the last couple of decades, we had a corresponding increase with the clinical practice guidelines. And that sort of reached a maximum point around 2014. So if we go back 2 slides now, but the important issue really when we're thinking about what happens in real world clinical practice is the translation of those best practice guidelines or clinical practice guidelines into what really happens in real world practice and also what's possible in real world clinical settings. So if we look at the acupuncture research, most of it is actually based on the efficacy and effectiveness clinical trials, and less so on the more recent pragmatic clinical trials. Now, the important difference here is in pragmatic trials, the participants in the trial receive treatments that much better reflect real world practice as compared to especially efficacy trials, which usually have a placebo control. So what we're talking about here, for example, with acupuncture would be a lot of the trials have only allowed the providers to give the patients acupuncture. But in the real world, Chinese medicine practitioners use a number of other modalities besides acupuncture. So things like Tuina, Chinese medical massage, gua sha, moxibustion, the use of heat lamps, dietary advice, lifestyle advice. All of these are important components of what really happens when somebody goes to see an acupuncturist. And they're important for pain, especially things like Tuina and gua sha. So we need to think about what are we going to pay for? Are we only going to restrict payment for acupuncture, or are we also going to be more mindful of the fact that we're therefore limiting other things that acupuncturists can do that would usually make the outcome more effective and obviously better for the patient. So then thinking about implementation, which is a very complex process. So we've got different settings. So there's big difference if you're to introduce acupuncture into a hospital as compared to introducing acupuncture into a federally qualified healthcare center. The stakeholders. So we've got to think about the referring providers, the providers that are giving the care, the administrators, etc. There's a lot of different stakeholders involved. Education. I've talked about interprofessional education. We especially need that in terms of referral and shared patient care. And then there's the sort of nuts and bolts, everyday things that are to do with process, like space that's needed, equipment that's needed, storage of equipment, scheduling, and all these sort of more mundane aspects that in the end, if they're not properly handled, can derail the whole thing. So the last thing I want to talk about is, what are we really talking about when we mention things like comprehensive and integrative? So integrative, the word implies that we're sort of going to bring different therapies together and in a sense fuse them together. But as those of us that have been working in these settings know, that's actually not what's happening. What's usually happening is more of a pluralistic system whereby different disciplines can come together and both be involved in the treatment of a patient, but each is allowed to operate according to its own theories and paradigms. So there's a mutual respect between the different disciplines that even though they might be based on very different paradigms, that those are legitimate and can be utilized to the fullest extent in deciding on patient treatment. So this sort of brings us into this whole topic of the different cultures and paradigms that are used by the different disciplines. And these can become very important issues if they're not handled properly. So this sort of brings us back to this point I raised about mutual respect and understanding based on interprofessional education. So the complementary and integrative healthcare clinicians need to feel comfortable in the biomedical settings. They need to feel that they have legitimacy and respect from the biomedical providers. And then lastly, as this complexity becomes more apparent, we of course have to think about the patient. And if we think it's complex and confusing, we can only just imagine what that's like for the patient. So we need to ensure really basic things like if they're seeing a number of different providers, that the messaging is consistent. So if we're all giving them different types of lifestyle advice and dietary advice, we should try to at least have a level of consistency so the patient doesn't get confused. And we know that when patients get confused, they usually give up. So choice, how are we going to advise our patients in terms of the choices of the different approaches that could be taken? And we need to be transparent. I mean, patients know when there's a level of confusion, and it's much better if we are open and honest about that so that we can optimize patient care. And on my next slide, that is all from me. Next two slides. Thank you.
Well, thank you very much to all the panelists. Unfortunately, we don't have time for any questions for the panelists live. The questions that people did submit, we will have answers for those from the panelists. But I believe that the information that everybody presented was exceptionally helpful and certainly great pearls of wisdom that you shared. So thank you to everybody. And we'll move on to our next and final panel for the day. And I'll turn it over to Amy. Thank you, Amy.
Thank you, Ravi, and thank you to the panelists. This was excellent, and it's a perfect seg into our closing panel. Again, to reiterate, just because this is important and we want to make sure you do hear this, you have all asked really excellent questions that we are also interested to hear answers to. So we will follow up with the answers, and we are moving into a final closing session to take time to synthesize and really think about what these 2 days have looked like and hear from a lot of different stakeholders in that process.